Let's read about Propofol Infusion Syndrome in detail. It was first seen by Bray in 1998. He saw that children who were on Propofol infusion developed this condition. It is described as acute refractory bradycardia leading to asystole with one or more of the following features like metabolic acidosis, rhabdomyolysis, hyperlipidemia, enlarged or fatty liver. Normally, it is seen in patients who are on infusion of propofol and are critically ill with a dose of more than 4 mg per kg per hour or duration of more than 48 hours. Predisposing factors or risk factors, all those conditions in which there is increased lipolysis, which is leading to increased free fatty acid. All those conditions will lead to propofol infusion syndrome. First is duration and dose of propofol infusion, and in obese patient you are using total body weight instead of lean body weight to calculate the dose of propofol. Second, pediatric, they have limited glycogen storage. So for demand, they are using lipolysis. That leads to increased free fatty acid. Lipid overload itself. Patients who are on total parenteral nutrition and they have lipid parenteral nutrition along with propofol, again increased free fatty acid. Infusions of catecholamine. What is happening in this? There is increased clearance of propofol due to vasopressor. Because of increased clearance, there is increased demand, leads to increased dose requirement, leads to propofol infusion syndrome. Again, in critically ill patients, there is increased neuroendocrine response that leads to increased breakdown of liquid. As we know, because of the increased neuroendocrine response, there is increased breakdown, increased free fatty acid. Inadequate carbohydrate delivery because there is decreased glucose and glycogen storage. So, demand is met by increased lipolysis. Again, increased free fatty acid. Genetic disorders, patients who have medium chain acyl-CoA deficiency are also predisposed to propofol infusion syndrome. Let's read about mechanism. What happens in normal mechanism first? The free fatty acid, long chain free fatty acid, makes a complex with carnitine, which is transferred inside the mitochondria for beta oxidation, electron transport chain, phosphorylation, and ATP production. What does propofol does in this? It inhibits at two pathways. First, it inhibits carnitine palmitoyl transferase 1, which is helping the incorporation of long-chain fatty acid inside the mitochondria for beta oxidation. Second, it inhibits the electron transport chain itself. As a result of this, there is increased free fatty acid, lipemia, there is increased acyl carnitine complex, and there is decreased ATP. All these factors leads to cardiovascular collapse and proarrhythmic condition. Let's read about clinical features. As per Henfield's classification, the primary features are ECG changes in which you will see curving of the ST in V1, V2, and V3, same seen in Brugada. You will see right bundle branch block. You might see VT or SVT. You will see new onset severe metabolic acidosis due to increased lactate or renal dysfunction. You will see rhabdomyolysis. Coming to secondary features, lipidemia, hyperkalemia, acute kidney injury, increased lactate, fever, cardiac dysfunction, deranged liver enzymes. There are a variety of secondary features. And how will you manage? You just have to remember three things. You have to stop the propofol. You have to give supportive therapy to all these conditions which we saw, and you have to eliminate by renal replacement therapy. In refractory cases, you might have to go for ECMO. Interesting points, you might see pancreatitis also, and there might be cases of catecholamine resistance. Why? Because of calcium channel blocking effect of the propofol.